Hi, I'm Dennis Schultz. I'm an occupational physician who was also trained in family medicine from the Milwaukee area, and I have been involved with NAWHC accreditation for about 25 years. So when I'm not on a day job, I'm usually doing something for NAWHC and have functioned in a wide variety of capacities with the organization.
Thank you, Drew.
My name is Drew DiGiovanni. 40 years ago, I began my career in occupational health in the sawmill country and saw a lot of amputations, a lot of really severe injuries. Went into primary care for several years and then started to work for a small company called Comprehensive Health Services, which is now known as Premise, and went through their growth process, and I'll be talking about that in their accreditation process as well. I currently work for Evernorth Health Services, and we're like the care delivery division for Cigna Health. Cigna has 165,000 people enrolled in their medical insurance product, and so we service some of them with on-site care.
Great. And John?
My name is John Bussell. I'm the Chief Medical and Operations Officer for QuadMed. QuadMed is a wholly owned subsidiary of Quad Graphics, Quad, and we are throughout the country, we're in 20 states, over 60 sites, and so we have a national presence, and we have a virtual primary care product over 50 states. My background is a family medicine physician. I was actually a hospital CEO in the traditional healthcare system for several years. I have a master's in healthcare management from Harvard School of Public Health, and have been with Quad Graphics for about 2.5 years. I spent a little time with Cigna, so Drew and I were able to connect on that as a market medical executive doing value-based care and population health.
Thank you. And Jennifer, why don't you introduce yourself, please?
Sure. I'll be moderating today's panel. I'm Jen Maniscalco. I'm with NAWHC. I'm excited to have this opportunity to share the expertise that is on this panel as we discuss how to measure the quality and value of a Worksite health center.
Great, thank you. And with that, I'll turn it over to Jennifer for a panel discussion.
Okay, I know we've got to catch up on a little bit of time. We've had the pleasure of each of our panelists getting their backgrounds. I want to talk just briefly about NAWHC. We are the leader in ambulatory healthcare, and with a mission of improving healthcare quality through accreditation, we are nationally recognized with quality improvement standards that are developed by ambulatory experts. The survey experience should be noted as it was founded on peer-based educational approaches. So that is collaborative, educational. How can we improve healthcare quality and ultimately improve that patient experience? We drive by the 1095 strong quality everyday philosophy, which means every single day we work toward the standards that are expected with our accreditation, with our certification. We have ongoing engagement with tools, with resources, and educational opportunities that really bring the value back to each of our organizations. So with more than 40 years of experience, we're based on encouraging and insisting that the ambulatory experience for our organization provides that high level of care for our recipients. So with that, I want to talk a little bit about every system is perfectly designed to get the results it gets. And just to look for a moment at the basis of this quote with Deming, Berwick, and Metalden, and if you Google that quote, you're going to land at a Dartmouth medicine newsletter. Dr. Metalden was influenced by the famous quality expert, Deming, and with Berwick, they collaborated. And if you think about that a little bit further, Dr. Batelden had actually a more specific quote to healthcare. And he said that if we keep doing what we have always been doing, we'll keep getting what we've always gotten, an expensive, high-tech, inefficient healthcare system. So with that, can you discuss how accreditation has helped unify your organization's processes and systems?
Actually, the slides did not address NAWHC processes. I'll spend a couple of minutes on that and then turn it over to my esteemed colleagues. So NAWHC, as an accreditation organization, developed these standards, and the standards are in chapters. Each chapter is a topic area. There are a number of chapters that all organizations that are going through the accreditation process have to meet. And they're basics like rights of patients, governance, administration, quality improvement, patient safety, and things like that. And then there are a series of chapters that are applied if an organization provides a specific service. For example, there's one for occupational health. There's one for imaging, if you're doing the x-rays or ultrasounds. There's one for pharmacy. So an organization that is interested in becoming accredited generally starts with that standard book, taking a look at it, and then dividing them up with different leads for each one, champions for each one of the chapters. At that point, they proceed to analyze their own organization, looking carefully at all different areas to see where there might be gaps between the standards and what they're doing. They implement changes, and at that point, they're ready for the survey. All of NAWHC organization, all organizations that go through NAWHC gets a survey, and I've been a surveyor for 25 years, so I've got to see a lot of very, very interesting organizations. It's a great experience. It's always a learning experience as well. Usually the organization goes through a mock survey just to make sure that they know what to expect when the surveyor comes in, organization becomes accredited, and then they proceed to prepare. If they're smart, and if they can be focused, because it's hard to do that as an organization, you immediately start preparing for the next one so that you can build upon whatever you did up to this point, and then you're ready 3 years later. So that's the typical process that an organization goes through. And with that, I'll turn it over to my colleagues to talk about what that process means in terms of your organization.
Years ago, I started in an organization with 50 health centers. Everybody did their own thing. There was no unified infrastructure at all. So I spent the first year really standardizing some of our basic processes, the patient experience surveys, some basic policy and so forth. But in year 2, I began to pursue the process of preparing for NAWHC accreditation, and the standards gave me a very clear roadmap for building what turned out to be a world-class quality program. And so it was a real clear pathway. I think that as we progressed, then we integrated the NAWHC standards into our audit processes so that all of our centers began to examine how were they complying with various standards and so forth. But it was an education process for them as much as it was a process of looking around the clinic. So it was a nice way using the audit tool or the survey tool, we call it a survey, to help leaders really understand and begin to experience the standards and learn about them and get their feet wet with them. We also then included our chart review standards from NAWHC into our peer review process. Very clear chart review criteria for peer review, for people to review others' charts, for us to do oversight, particularly in our orientation process as well. So those are some of our really clear integration points that helped us excel.
Yeah, and then last night at dinner, we decided the panel's been way too agreeable. So I'm going to try and find something to disagree with today. We're going to work on that. I agree with everything so far. So for us, and in my path, accreditation, I've had a lot of different viewpoints. So as a practicing physician, accreditation was very fear-based. So, oh no, the Joint Commission is coming. We have to get everything ready, get all the snacks off the nurse's station, and be ready for the surveyors to come. And then stepping into a hospital CEO role, I've really developed an appreciation for the processes, the standardization, the sharing of best practices that we can get from a surveyor. And going through that process as a leader of an organization, it really helped me feel better about the processes and everything that we're doing it the right way. So coming here into Quad Med, we're going up on our third triannual survey later this year. And so everything that we've done over the last 6 years has really improved us to make us a better organization, to standardize across the board. And even in the last 3 years, we continue to improve. We're adding on new automations and new software for policy management, for our credentialing software. Everything that we're doing right now, I feel really good about. When the surveyors come in, they're going to feel even better than they were at the last survey. So, for us, it's not about just having one clinic that has the letters behind their name to say we have this certification here. We're not just checking the box. We're really trying to integrate the best practices that an accreditation body has and standardize that across all of our clinics. Some of our clinics are accredited, some of our clinics aren't technically accredited. It doesn't make sense for all of our employers, all of our clients, the OpHealth clinics to be accredited necessarily, but we have those same processes all the way throughout the organization. And so it just makes us better all the way across the board and makes us all sleep better at night in the C-suite.
It's on? Good. There we go. All righty. So, first off, that quote is exactly right, because when you go through your self-study, and I've done this with organizations as well, as when you get a surveyor, they will always have been on the other side of the table. So they've already been with an organization, usually involved in their process of accreditation. So we know what it feels like either way. But that quote is exactly correct, because during that self-study where you look at all your systems, that's where you actually get more benefit than when the surveyor comes in usually, because you find the things ahead of time, you identify them, and when you run into glitches, more likely than not, you've got a system issue that is resulting in getting the results that you see right there, and so you change that, and then you go take a look at other clinics, if there are other operations that you manage, and see what's going on there as well. The standards and the process apply to single provider clinics, to multi-provider clinics or multi-specialty clinics, as well as organizations that manage a number of clinics. And there is a program where you can choose which of your clinics you want accredited if you have a lot of clinics that you operate. So if you want to find out which one has actually been accredited, look for the certificate as you walk in.
Okay, let's delve further into quality and talk about quality is never an accident. It's always a result of intelligent effort. Once again, we have another quote from our quality improvement thought leaders. The question I have is, can you discuss quality improvement studies that your organization has participated in? And think about the sizes of different organizations and the various resources that are needed for those quality improvement efforts.
I'll do one more brief introduction to this, and that won't take more. So NAWHC has a quality standard, which is part of their core standards that all organizations must meet. And it's got several elements. In essence, what it says is you as an organization have to define what's important to you, and then you've got to figure out how to measure that and how to improve that. So whether good or bad, there aren't a set of metrics that you have to submit for NAWHC, either on the occupational side or the primary care side. But what you have to do is go through your own system. And as a surveyor, when you come in, you take a look, and if they've got a bunch of metrics that are going on, and none of them are clinical or none of them are administrative, you comment on that. But the organization does that as part of the accreditation process. They have to identify both internal and external benchmarks, and then they've got to be able to demonstrate they know how to make improvements, and that's the quality improvement study. It's a very systematic list of things you have to do in the process of doing your study to ensure that you've identified the issues, that you've addressed those issues, and that they have in fact caused improvement that's sustained, or you're going to go back in and do it again. And it's a fascinating standard. It's stood the test of time. It's one that was there since the beginning in '79, and it provides the flexibility but it also, it's challenging, but fun to be. It's always fun to evaluate that standard when you go into a clinic and take a look at it.
I have a number of colleagues who have pursued a Six Sigma Black Belt certification and never made it to the end, because I think that they were accumulating so many tools that it became paralyzing to them as they tried to implement them. Some people have been successful, but in smaller organizations, it becomes overcomplicated. I got the opportunity to study with Paul Taudin at Dartmouth with the microsystems method, which is really going down to the front line. So even if we are seeing a problem at the corporate level, problem data, and as an example, we had a number of health centers that were really missing the mark in terms of doing medication reconciliation. We took that to one clinic and said, please help us solve this problem. So instead of people at the corporate level trying to solve it, we're getting a physician, an NP, an MA, someone from reception coming together as a team to solve and work through cause and effect, and then solve the problem. It sometimes can take a couple of tries. And one thing I'm often telling clinic staff is, you may have some great ideas. Your first try may not work. It's okay. It's normal to have, a second round of a quality improvement cycle to understand what the problem really is and how to improve it. But then taking what the front line has suggested for improvement or implemented in their clinic back up to the corporate level, I have found to be really successful. So it's that front line that really understands the problem better than us at the corporate level, and then getting to really send it up. At the clinic level, not at the corporate, I would see that we talked about this yesterday, wait time being probably one of the biggest topics for quality improvement studies, because that is a very sensitive issue in our industry. So.
So I'll add on to that. I do agree. I think it's really important that we have quality improvement studies that start at the clinic level, but then as a networked company, to make sure we have system-wide quality improvement studies as well. With QuadMed, we're very fortunate to have our parent company, Quad, because they are a printing company. They're a manufacturer of parts, so we have a continuous improvement arm that can really help us with all of our processes and workflows and dive into our individual clinics from a continuous improvement pathway. That means Six Sigma type of thought process. And then we also have quality improvement where we're tracking all kinds of quality metrics through our EMR Epic, and then doing individual quality improvement studies at the clinic level. Some of the system-wide things that we've done to try and improve our processes are, we were having some vaccination errors. As vaccines were coming out, they became very complex. Now we have a purple top, we have a red top, we've got, for this pediatric dose, you're going to have green, and now you have 2 of these and 3 of those. And it became really complex. We were sending out communication on a regular basis. But one of the things that I think we need to really consider when we're building quality improvement projects is that education is never an effective long-term intervention. And I can just say that again. So if you try to educate somebody, if you're just going to do education, you're going to miss anybody new who's coming in. They're going to forget it over time. It's not a long-standing intervention that is going to actually make a change in the long run. So developing an intervention that stops people consistently, so like a best BPA in your EMR, a best practice advisory, that hard stop that makes people read it and do something different with that information is really effective. So with vaccines, we started barcode scanning all of our vaccines. And by doing that, we were able to have a BPA pop up every time we did a vaccine to ensure it was the right patient, right dose, right time every time. And so that's one of those system-wide quality improvement studies that we tracked and saw a significant decrease in our vaccine errors across the company. And then individually in the clinics, it can be as simple as we're just looking at our workflows and how we get patients in. The wait times is a great one for each individual clinic, because they all have unique workflows for getting patients in and structure the clinics and how they're set up.
I'd like to comment also the use of control charts to consider how are we looking at sustained results. So when we're doing this intervention and we're putting the system in place as opposed to just relying on training or individual behavior, are we monitoring over time? Because I see sometimes that we fixed it, we said, oh, we fixed it, but we may see performance drop. So it's important to monitor for at least a year, perhaps even 2 years after doing a QS study.
Well, let me echo the comments about education. As a provider in the system, the universal response when there was a problem seemed to be, let's get the docs and educate them with something else. And in short term, it might work, but long term, you really do like system changes. Anyway, as you might guess from this, that this quality improvement is important for organizations that are small and are big. And the issues for wait times or other ones, those are universal. How you tackle them with the resources that you've got and the number of patients you see will vary from place to place, but it's designed in a manner that any organization can demonstrate they know how to improve quality and make a difference in whatever area they want to. I just did a survey of an organization that had one physician assistant with some backup with a physician who was off-site. And they did a study on increasing mammograms. They started off by calling, it's just when there was time, they got a list of individuals, there weren't that many that were being referred out, and they called them, and they found out that a lot of them had gotten their mammograms, but they never got the result. Well, that went to the next phase, that is how do we get the results consistently, and talking to places that offer services in town. And then that improved things a little bit more. They were close to what they wanted as a goal. The last episode is we're going to do outreach and education and then try to encourage folks that way. I've got the two of them. And you commonly see interventions stacked up on another, just the way it works out, and then you have to worry about sustaining it. But that's done by small organizations and big ones. I remember a phenomenal study that was on opioid use, and took a look, and this was in a large system, looked at who was prescribing what. There was an educational program, but they also provided support and mentoring, so groups of providers would actually get together and discuss. And so one thing led to the next. It wasn't a one and done. And you see that on school points as well. Thank you.
Thank you. Let's switch our focus just a little bit and talk about measurement. If you cannot measure it, you cannot improve it. This quote is attributed to Lord Kelvin, who is known for the laws of thermodynamics and contributed to unifying physics. When we think about organizations, how would you utilize internal or external benchmarking tools to improve the quality of care provided? And I'd also like to take the time to make sure that we're distinguishing between benchmarking and quality improvement.
No introductory comments. Go ahead.
Yeah, so I mean, when we're looking at benchmarking, it's really important for us that we use quality metrics that we can compare ourselves to other organizations. So we like to keep this, NCQA, anything that has a national benchmark that we can compare ourselves to that is meaningful. There's not every quality metric is going to have a great national benchmark. So we do our best practices. We will get some information from our partners, analytic firms, and try to come up with an appropriate benchmark for us to try and exceed. Ultimately, we want to exceed all of these goals. We don't want to just have our goal set at what a national community practice would have. We want to exceed that. With our model of care, we should be able to do that. But ultimately, that's our stance on it. So we want to try and have something that is nationally recognized. We're not just making it up and trying to show our clients that we're doing great based on some made up goal that we have. But also, we do want to make sure that we are continuously improving and trying to exceed those goals.
I've used process and operational benchmarks as well as HEDIS and clinical. So as an example, the Medical Group Management Association publishes a lot of operational benchmarks that look at staffing ratios, look at exam room ratios, and what you can expect in productivity based on your current facilities and your current staffing. And so I've often used that to level set expectations. If you're going to have one exam room per provider because we have limited space, we can't expect this much productivity. If you're going to have 2 exam rooms that are shared between 2 providers, we can't expect this much productivity. If we add space, if we add MAs, this is our pathway to get to the goal that you'd like in terms of primary care productivity. And I think that's real important. But also using HEDIS data to level set with clients as well. I've had, let's say, a CMO from a healthcare organization who wants their population of employees who have diabetes to be 90% under control within 1 year. And so we can come back with HEDIS to say, in your region, the highest performance is going to be in the 60 to 70%. And that's not going to happen in 12 months. So I think HEDIS has also helped us to level set. Mostly I've used benchmark data to also trigger quality improvement studies. So we've set the threshold, everyone who's meeting it, good to go. But those who are falling short then are required to do some process improvement. And it's a nice trigger, it's fair, and we're really looking at helping people enter into the QI process based on their data.
So those external benchmarks are critically important if they're available. Sometimes they're just not, depending on what you do. You know, occupational health is an example where it's just hard to find external benchmarks of one sort or the other. But when you got them, in primary care, certainly there are an awful lot of those available national benchmarks. They are the ones that's valuable for identifying what your goal is, what you are actually shooting for. Where you can have internal benchmarks from one facility to the next, such as QuadMed or other vendors that manage multiple clinics, that really can be helpful in identifying how are you going to get there, who's doing what, and if there are differences, why, and then amplify those differences that improve things, minimize the differences where you see it's not improving things, and it can be extremely valuable to use that way.
And I'm going to touch a little bit on operational benchmarks. So MGMA is great for community practices and that sort of thing. It's really hard to take some of those benchmarks and bring them into our model of care where we have 30 to 60-minute visits. Things are very different in our world than they are in the community. We also aren't incentivized to bring patients in for reimbursement, so we don't have to see a patient face-to-face or even virtually to bill their insurance and get paid. We can manage a lot of things asynchronously, so through MyChart messages and everything in between. So a lot of the operational benchmarks can be really hard to bring into our model. So we do end up creating a lot of our own to be able to say, this is what you can expect for a new client as far as productivity goes, and try and create more of an apples-to-apples comparison of, we have smaller patient panel sizes, and the reason that we don't see patients as often or as frequently is because we don't have those misaligned incentives. But then also we're able to manage a lot of these things in between visits, keep your patients out of the ER and urgent care because of all this. So just all that to say, we have to be careful when we use these benchmarks because it may not always align with the model of care that we're delivering.
I wonder what Lord Calvin would think of this discussion. Let's look at this quote from Steve Jobs, which is, be a yardstick of quality. Some people aren't used to an environment where excellence is expected. Anyone not know Steve Jobs? So what advice can you offer to a worksite health organization on how to engage staff in quality efforts?
I have inherited clinics that were either run by the employer or by another organization where there was a lot of chaos as we came in and were onboarding them and getting the team settled, in part because their roles were not clear. MAs just, were in one orbit and the providers were in another orbit, and it's getting that team aligned. So I think that alignment in terms of getting role clarification is an important foundation for quality in general. And I think, again, back to the microsystems approach, it's getting that front line engaged in quality improvement. Everybody has a role across the organization, not just some people in some organization. It is really spreading that activity across there. I would finally just comment that in terms of educating the front line or even senior leaders with NAWHC standards, it's so important to be using adult learning. I see some of my colleagues doing a lot of lecturing to people and saying, we have to do this and here's a standard, and they'll spend hours just regurgitating standards over and over again. So I think that, using adult learning, letting people have experiential learning with the standards is important. We've even used, game shows at leadership retreats. We had NAWHC, Jeopardy, and so forth. But helping people kind of understand and absorb the standards on their own time. And then certainly mock audits, and as I mentioned, our audit process, really helping people to begin to look at quality from an audit or survey process and look at the standards and say, how are we doing? Let me go look in this cupboard and open it up and see how medications are stored, how they're administered, and so forth. So that experiential learning, I think, is critical.
Yeah, and I think for me, when we're trying to engage people, especially frontline staff, in quality improvement and get them excited about what we're doing, one, it does take a lot of leadership support. You have to have buy-in from the top down. It's not just, you guys go do this and let us know what happens. We have to be involved in the process. But we also have to make sure that we keep it simple. So at the very beginning, it has to be simple for them to develop an understanding that they have a problem to solve, and we're going to give them a framework on how to start solving their own problems at the clinic level. Once they solve one simple problem, they get a little bit more excited about it, and it builds. And over time, with the framework of continuous improvement, quality improvement, you get a lot of buy-in. You get people really excited about it over time because they keep seeing that improvement. They see all the problems that they're solving, and their lives keep getting easier. Their processes get a little bit more simpler, and you get that buy-in engagement over time.
Well, let me echo that about senior leadership. Well, actually, everything you said was, I can't find anything to disagree on. No, sorry. No, that senior leadership is real important. And you can tell as a surveyor when you come in, there's usually an introductory conference that you have, and at the end there's a summation conference where you review all the results. And if you've got people from the leadership group that are in there on the initial one, you already know that there's a lot, that the organization's got a lot better chance to succeed in all the different areas. Likewise, you don't want micromanagement. You want to set the expectations, you want to be consistent with your messaging, you want to be constant with your messaging, and have leadership direct, and then move back and see what happens. Making it fun is important too, and it is possible to do that, strangely enough. You heard about it wasn't bingo, it was Jeopardy. It was Jeopardy, and I've seen that as well. Having folks compete with their quality metrics, you can do that too to see who's better, and you can get that rolling. It's strange within the organization I was in. If you found a glitch or a problem, people started panicking, and I said, hey, we got an opportunity for quality improvement here. We could really look good for the survey. Anyway, yeah, that's it. And when you run into one of these organizations that's fully engaged, as a surveyor, you might actually ask somebody at the front desk or somebody else, or if there's a room where your folks gather for lunch or such, and ask people about, say, so what do you think about this process? What do you think about, and see what sort of responses they give you about their engagement as well.
Dr. Schultz, can you also add a little bit of your thoughts around how quality improvement is important for the individual in their own personal development?
Well, it teaches very important skills, just a whole wide variety of those kinds of skills. And the systematic process that you use to try to figure out where the problem is, why it's occurring, is valuable in life in general. So I think participate. And not only is it valuable for the individual to go through it, obviously valuable for the patients or whoever the organization is serving, but it's fun. It does change your thought process a bit.
Just to build on the comment around the Kirshner Awards, these are, Dr. Schultz had mentioned those are awards that are done annually since 2004 at NAWHC, and it's awarded to a primary care and surgical care study that demonstrates their quality improvement award. One comment that I continually get from those winners, I always like to understand the studies, but I like to understand what's behind it. And universally, they will talk about their success being a result of the leadership buy-in, the entire organization buying into the process, and that is a key component in their success. This is an example of some of our accredited organizations. So just wanted to take the time to highlight QuadMed, Worksite, Premise, CARE-ATC, Progressive, as well as our Coast Guard, Crossover, Vanderbilt. So we're just want to take the time to recognize those organizations. Questions, comments? Perfect. Time. I've got two questions here. The question is, what is the cost to engage NAWHC? What is the cost to engage NAWHC? I'm not sure. It's a cost to engage. Okay. So in that case, so what we would do is there would be an assessment of the size of your facility, the number of surveyors required, what types of procedures are done. So there's quite a process that goes into determining what the cost is. The great news is we have an entire team of accreditation specialists that will go into those details, as it is a handheld number. The next question is, how do you align compensation with the quality outcomes for patients?
So I assume we're talking about provider compensation. And I think that's a really interesting question. The typical fee-for-service world pays typically by RVU, so with a painful production, they're getting what they're trying to achieve by seeing more patients, getting more revenue coming through the door, more referrals coming up to their specialists. And the way that we've structured it is similar to what Cleveland Clinic has done, where they pay physicians by salary with quality bonuses, so that we're really focused on taking care of patients. That's really the number one focus. And then have that quality being the only reason that we would give them any additional compensation. And so by structuring it that way, we really have engaged providers. We also have to hire well. You have to hire the right type of provider who's going to want to engage in quality scores and population health. A lot of what we're talking about here with quality improvement and the quality metrics that we're looking at is truly a population health effort, because it creates outreach, opportunities for outreach. It drives that population to hit the cancer screening, the chronic condition management quality measures that we're looking at. And so really for me, it comes down to having a process around the providers and not having compensation be a part of that conversation. Really the bonus metrics should be achievable every year with the patient population that they have. And so it really comes down to just driving with our metrics, transparency, and keeping them accountable that way.
And the important component, as as you're saying, is having the infrastructure to support provider excellence and staff nursing excellence. So incentives are one aspect, but it's really having the foundation to support those out in the field.
No comments about that, but I was thinking advantages to individuals who participate in the process. Pride. When you walk in as a surveyor and somebody tells you what the team describes what they did on the quality study and it made a difference, they glow. They simply glow. Once they're past any panic, there's a surveyor there, then they glow. The other thing is that there was a list of organizations that accredit, but individual organizations too. There was a couple there, but even Oak Ridge National Lab. They had presenters yesterday, and they're accredited by NAWHC as well in the occupational health arena.
Any final thoughts as we wrap up about preparing for an accreditation survey?
I'd recommend starting small. NAWHC offers a network accreditation. You can accredit 15, 20, you can accredit all of your clinics, but starting with one, if you don't have accreditation experience, even if you have experience with other accreditation bodies, Joint Commission, CARF, I would recommend, accrediting 1 or 2 clinics, getting your feet wet or getting, settled into the standards, and then building the standards out into your policy and procedure at the enterprise level, and then expanding from there. Start small.
Yeah, and I would look at all the information that NAWHC has. They have a lot of guidelines and guideposts, but what NAWHC provides is really a skeleton for how the organization should be functioning. Every organization is so unique. It's not that they're mandating that you do certain things, it's that there are some best practices, these guidelines that you should be following. And so you can look through the NAWHC handbook, see how close you are to hitting a lot of the guidelines that are in there, and then start shoring up some of those processes earlier rather than later if you see some major gaps.
John and I were talking last night about the adoption of technology and how our organizations, whether it be credentialing software, policy management software, risk management software, incident reporting, complaint, pipeline software, some of these packages are very inexpensive. If you're a small organization, you may pay only $3,000 a year after implementation. You're going to pay more if you're larger, but really the efficiency that is found and the ease of achieving these standards, I think is enabled by tech.
Yeah, and the technology is not required. I mean, for our first survey, we didn't have policy software or internal credentialing software. We used an external credentialing vendor. So I think that it's not a requirement to be able to do it, but as you go through the process, like we found, it does make your life a lot easier, as a lot of efficiency takes away a lot of the manual processes that you're either currently doing or will be doing in the future.
And we'll certainly hear, I know that Larry's got a couple other things he wants to present, so we are here to help. Myself, Renee Greenfeld, who's also here, who's our Senior Vice President for Marketing and Business Development. And please stop by, chat with us, and we're excited to hear your questions and want to share our thoughts with you. Thank you so much to our panelists, Dr. Bunzel, Dr.
Thank you very much. So what I want to do now is to give you more of a broad perspective on measurement. This is something that's been developed by the NAWHC, and it's an initiative to assist people with measuring the performance of worksite centers. And so I want to go through some of the major categories. So we don't have to describe NAWHC, you're all here, but clearly our focus is on improving the value and quality of worksite centers. So there was a report done by Towers Watson a number of years ago, which essentially found that employers who had the best kind of performance and productivity and outcome tended to be those that invested in their human capital. And particularly through worksite centers, that's how you go about doing that. For example, one of our members, Union Pacific Railroad, you may not know, but sensors in the railroad tracks all over this country to determine when $1 million locomotive is starting to falter so they can repair it. Well, the same thing, employers need to invest as much of their human capital to make sure their chief operating officer, their salespeople, their call center people, their security are in top priority, and worksite centers are those that need to measure that. The question is, how do you know your system's working? So there's a variety of objectives that you can take. Every employer is different. We talked yesterday in the results of our survey that productivity, of getting people healthy, reducing costs, reducing absenteeism, improving satisfaction, improving recruitment and retention are all key. But it makes no sense for you to have an objective if you don't measure it. You can't just put out these balloons in the slide presentation unless you have some way to know if you're accomplishing your task. So we find that a lot of employers just don't have the data, or they don't integrate the data. And it's really key that that's what it all starts with. It starts with knowing what's your population's major conditions, what's the prevalence of those conditions, what's the cost, are people leaving, what's their view of the engagement, are they participating in your programs, and then do you actually measure? And unfortunately, we have a number of employers who do not even measure. And when I was the head of the Midwest Business Group on Health, we found this historically. About a quarter of employers never measured any of their wellness programs, smoking cessation, diabetes management, EAP. You can't get better resources, you can't improve what you're doing until you measure. So measurement, in our perspective, is more than just return on capital. It's more than our OR. It's what we call the VOI, value of the investment. And these are all the key areas that we think you need to look at. You need to look at what are the care indicators. What activities do you have? What is the health status of the population? Are you measuring those? What about the financial indicators? Are you avoiding people going to the ER, urgent care center? Are you keeping people back? Are you, what's your comparison of CPT codes for the services you have in your centers compared to providers offering those exact same CPT code services outside of the centers? What about productivity? Are people staying on the job? We find it when someone needs to leave work to get something I mentioned yesterday, they're gone 3 to 4 hours. If you multiply how many people are gone 3 to 4 hours by the average salary of the company, you get a pretty good feel of what's the impact of people not being there. What about the administrative indicators that are doing it? Provider productivity and accountability, the mix of providers, the wait time, and of course satisfaction. And not just satisfaction with the center overall, but what about the providers, the registration system, the quality of care, a variety of things, and access. These are all things you need to focus on in addition to recruitment and retention. Now, not every center has the data for all of these things. Not every center is focused on them. Not every employer is. But if you, and you can use this for any wellness and benefit program you've got, but particularly as it relates to worksite centers, it's key that you take a broad perspective because many of these things you can accomplish and you can measure in 1 year, but some other things could take 3 to 5 years. For example, reducing the number of risks that an individual has, all key. When we ask employers, and generally in our membership, have you achieved your health and productivity objectives or wellness objectives, you can see over 60% of employers are all-siders. And the way you read the slide, the blue-colored column is those who have less than 1,000 employees, the orange is those with 1,000 to 10,000, and gray is over 10,000. But uniformly, you're finding that employers at worksite centers who have addressed their health and wellness, have identified objectives, are pretty much meeting them. Same thing on financial and reducing. These are all the different areas you could be reducing costs for worksite health centers. And so many employers are finding they're attaining these objectives. And again, it could take time, but you've got to have the data. You've got to see the totality of the population. You just can't look at the center's population. You have to see how does the center's population compare to the total population, those using the community, the non-users, etc. So the key measurement areas are similar to NAWHC that you want to focus on. You want to look at the administrative areas. Are people being engaged? It's just a sidebar. Again, when I was at Midwest Business Group, which is a business coalition, we worked with all the health plans in Illinois, and we asked the health plans, what % of our diabetic employees are being helped by your programs? And the Blues said, oh, we got 85% of your employees signed up for our programs. We said, well, how many are completing the program? About 12%. Well, so what's the value of that program if people are not engaged, completely involved with it? Utilization of the center, clearly. are people going in the door, and not just the general population, but those high-cost people, those people who overuse the system, who are primarily using the emergency room for their primary care. Are you getting them? Are you reducing the number of people leaving work? Financial, clinical issues as well. You know, are people reducing their risk? Are you improving health care? Are you improving their participation in the flu shots and other programs? And of course, satisfaction in all these areas. But again, you can't measure it if you don't have the data. If you're a brand new center, you can't measure all these things. So you have to look on the maturity of the center, the participation of the systems you have, the length, and your interest in drilling down. You know, are you more concerned with how many people in our center are on generics, or how many people in our center are adherents of statins? We have to decide, where is the drill down, how much do you want to look at that? So the key elements is, we talked a little bit about this yesterday, is if you're going to do measurement, you've got to remember, it's the Worksite Center partner that's going to have the systems primarily. Only about 18% of employers do this themselves. Most contract out. So does your partner have the tools, and do they share your definition of what is a patient? What is in the numerator? What is in the denominator? What is utilization? Who is to be covered? Is it the total population? How are you measuring all this? You need to decide these at the very start, or at the end of the day, or when performance guarantees are reviewed, or when the contract's being reviewed. You won't be able to determine whether, in fact, your partner, your center, your services are meeting your objectives that you created in the first time. So what is a health center patient? Is it someone who's there once a year? Somebody who's there for all their care? Someone who has a primary care doctor? Somebody who is eligible for the population? You have to make a decision because it impacts how, again, you determine whether you're meeting the goals that you set out there. So when we ask in general of our population, how do people determine what is utilization? We find most people are looking at the total clinic eligible population. And again, every employer determines it differently. It could be everybody covered in the plan. It could be active employees. It could be active employees and dependents and spouses. It could be anybody who has access to the center. So it all varies, and it's up to each employer to decide. But again, you've got to have an agreement with your partner, your worksite center vendor, your health system, whoever's working the center for you. Types of reports. This is really important. It doesn't make sense to collect things if you don't get it in time to make improvements. So there's certain kinds of reports you want on a weekly basis, some on a monthly, some on a quarterly, some on semi-annually, and some on an annual basis. So you want to make sure that you cover these things and you have the categories you want to look at and you see them quickly. So utilization is really key. If you're having problems with utilization, you want to know that right away. Provider capacity and use and appointments, you want to know that right away. Other things can take a longer time. So at the end of the day, what are the lessons learned that people tell us about measurement? Number one, decide on your objectives. First of all, what do you want to measure? What's the purpose of your worksite center? What are you trying to accomplish? Then create measurement approaches and metrics that meet those. And do that in partnership with the entity that's managing your center. You want to get agreement on the numerators and the denominators for those reporting. You want to make sure that your vendor partner understands the objectives, they have the tools, they have the capability, they have the data, and they have the knowledge. And in fact, I would highly recommend that you make sure you talk to them before you sign a contract. So in your RFIs, in your RFPs, you should be saying, our expectations is that you measure these things and you have the tools and data and ability to do so. So you want to find out ahead of time before you end that beauty contest of selecting your partner if they can do it. Because you don't want to do it after the contract is signed and all of a sudden they can't deliver on what your expectations are. You want to create, again, performance agreements and contracts based on your objectives and the targets you jointly come up with. Don't come up with your own target. Talk to the vendor because there may be things you think you can do within a short period of time and you can't, and the vendor will be able to help you with that. Set the expectations for senior management appropriately. They may think, oh, we're going to recoup all this money or people will change in productivity within a short period of time. It could take 3 years or more to do some of these things. Make sure that they're aware of it as well as you. Use the results to support your reporting for increased resources. Your CFO, your financial director, You've got to have hard data. Presenteeism is great to talk about, but it's no hard data. You've got to use some of these other factors and use a VOI approach to show them that you are reducing the need for replacement workers, that you're reducing absenteeism, that you are improving productivity, keeping people healthy on the job, and reducing people leaving work. You want to identify the reports you want and when they're wanted, and finally you want to make improvements in those. So we have a book called the Guidebook for Measuring the Performance of Worksite Health Centers that was developed a number of years ago. We just finished our 7th version of it. It's a long book. It's about 45 pages, but we've created an executive summary in 5 pages that covers all the major areas, and then we have a variety of contributions. It's free to members of the NAWHC at $125 who want to just get copies of that, and it covers all these different features I show on the far left side. So with that, I'll take any questions that you have. You can text it to me, or I'll take the questions on the microphone. I overwhelmed you too fast. Have that problem. Okay, so what we're going to do now, that we're going to have a break. Again, this is the last break of the program. Please complete your bingo cards. Leave them in the front. I would ask you to come back here for the final 2 sessions. They're both going to be excellent. One